Anginal pain is the critical alarm that signals myocardial ischemia. For clinicians, it represents a complex interplay of factors, from epicardial obstructions, microvascular dysfunction, coronary spasm, myocardial diseases, and valvular lesions. Regardless of the underlying mechanism, angina profoundly impacts our patients' lives. And this episode of CardioBuzz is the fifth part in our review of chronic coronary syndromes. For a complete and nuanced understanding of the landscape of chronic coronary disease, I urge you to revisit our previous episodes. In the first episode, we've covered the critical steps in diagnosing chest pain. In the second episode, we discussed the evidence-based medical therapies that aim at preventing MI and death. The third episode covered the evolving role of revascularization in stable coronary disease. The fourth episode was dedicated to the diagnostic and therapeutic challenges of ANOCA, angina with no obstructive coronary arteries. Today we'll be focusing on the practicalities of alleviating angina pain and enhancing the quality of life of patients with coronary disease. We'll dissect the medications and the procedures at our disposal, moving beyond theoretical discussions to the actionable insights that inform our daily practice. Welcome to CardioBuzz.
Welcome back to CardioBuzz, the essential channel for doctors looking to stay informed in cardiology. Whether you're a seasoned physician looking to quickly catch up on critical updates, or a fellow building a robust foundation, our videos offer the perfect balance of detail and efficiency. Don't miss out. Subscribe now and make CardioBuzz your trusted resource.
We all recognize the cornerstones of chronic coronary disease management that lies in addressing the underlying pathology and preventing adverse cardiovascular events. We do that with antiplatelets, anticoagulants, LDL lowering, using SGLT2 inhibitors and GLP-1 receptor agonists in diabetes, with the added benefit of semaglutide in obese patients with established disease, and with anti-inflammatory agents like colchicine. These are our fundamental tools in modifying disease progression. However, these therapies do not always translate to immediate relief from debilitating angina. This brings us to the crucial second arm of our therapeutic strategy, which is angina relief. Today we'll explore the medications and the procedures that specifically target improving our patients' symptomatic burden. It's also critical to acknowledge the unique role of revascularization. PCI and bypass for significant epicardial lesions offer a dual benefit. They not only provide superior symptomatic relief compared to medical therapy alone, but as the recent meta-analyses have shown, they can also significantly reduce the risk of cardiovascular death and spontaneous myocardial infarction when they are performed appropriately, of course. Beyond revascularization for high-grade lesions, we have a diverse armamentarium of medications and several intriguing procedural options that hold the promise of alleviating anginal symptoms. Let's begin with a detailed examination of the pharmacology. First, we need to acknowledge that we don't have head-to-head trial evidence comparing the efficacy of different anti-anginal drugs for symptom improvement. This absence of large-scale comparative studies necessitates shifts away from evidence-based medicine towards individualized patient care, where our clinical judgment and understanding of the strength and weakness of each agent becomes paramount. Secondly, while these medications are effective at relieving chest pain, it's important to emphasize that we lack evidence from multiple large randomized controlled trials that these agents consistently reduce major adverse events like myocardial infarction, heart failure, or death, with the notable exception of beta blockers in the first year after a myocardial infarction. This underscores the importance of our disease-modifying therapies that we have discussed earlier. Thirdly, and perhaps most commonly in our experience, effective angina management often requires a multi-drug approach. Therefore, a thorough understanding of how these agents can be safely and synergistically combined is essential for optimizing the patient's outcomes. Therefore, ultimately, we will need to tailor the anti-anginal therapy. And there are many ways that we can do that we will discuss shortly in this episode. But before we delve into the art of tailoring, let's take a detailed look at the pharmacological agents themselves, exploring their mechanisms, advantages, disadvantages, indications, contraindications, strength, and limitations. We can broadly categorize anti-anginal medications into two groups, hemodynamic and metabolic. Hemodynamic agents directly influence the coronary blood flow. They dilate the coronary vessels, they lower the blood pressure, they lower the heart rate, thereby modulating myocardial oxygen supply and demand. Metabolic agents, on the other hand, exert their effects at the cellular level, enhancing the myocyte's resilience to ischemia, without directly altering the hemodynamic parameters. Let's start by nitrates. Nitrates offer a multifaceted approach for anginal relief, but their use is not without caveats. They effectively dilate the large epicardial coronary arteries more than 100 microns. They reduce the conduit vessel resistance, and they improve the blood flow to the ischemic territories. Furthermore, they can dilate the collateral vessels, and this can provide crucial indirect perfusion to the jeopardized myocardium. At higher doses, nitrates reduce the systolic blood pressure through arterial vasodilation. They decrease the cardiac afterload, and they also have a vasodilatory effect that lowers the preload and the left ventricular end diastolic pressure, contributing to reduced myocardial oxygen demand. Nitrates are particularly effective in combating epicardial coronary spasm because they relax the smooth muscles in the epicardial coronaries. We have a range of nitrate formulations at our disposal, short-acting sublingual nitrates as sprays or tablets for the immediate relief of acute episodes, longer-acting preparations, dermal patches, extended-release tablets. They provide sustained symptom control. And of course, we have intravenous nitrates for a titrated hemodynamic effect in acute situations. However, we must consider the limitations of nitrates. They have minimal impact on the precapillary arterioles, less than 100 microns, and they do not dilate the capillaries. So they are less effective in cases of pure microvascular angina. Also, their cerebral vasodilatory effects can lead to troublesome headaches and increased intracranial pressure in susceptible individuals. Also, the development of tolerance with long-acting formulations can diminish their efficacy over time. Perhaps the most critical contraindication is the concomitant use of phosphodiesterase 5 inhibitors like sildenafil or tadalafil, which can precipitate life-threatening hypotension. Moving on to beta blockers, we have several generations of beta blockers offering varying degrees of selectivity for different beta-adrenergic receptors. Their primary antianginal mechanism involves increasing myocardial blood supply by slowing the heart rate, thereby prolonging the diastolic coronary filling time. They also reduce myocardial oxygen consumption through their negative chronotropic and their blood pressure lowering effects. Beta blockers can be particularly helpful in patients with heart failure because of their beneficial effect in improving ejection fraction, as well as in patients with hypertension. However, it's crucial to remember that beta blockers can paradoxically promote coronary spasm by blocking the vasodilatory effect of beta-2 receptors. Therefore, they are generally contraindicated in patients with known or suspected vasospastic angina. While often considered first-line agents, beta blockers have not demonstrated a reduction in major adverse cardiovascular events beyond the first year of the myocardial infarction. Furthermore, their side effect profile, including asthma exacerbation, fatigue, nightmares, erectile dysfunction, can significantly limit their tolerability and use in many patients. Calcium antagonists are potent arterial vasodilators. They lower the blood pressure and they can slow the heart rate. They can dilate both the epicardial coronary arteries as well as the arterioles. This dual action increases the myocardial oxygen supply and reduces the demand. They were historically grouped with beta blockers as first-line agents. But again, they have not shown a consistent reduction in MI, death in clinical trials. The dihydropyridine class can trigger reflex tachycardia, which can increase the myocardial oxygen demand. Non-dihydropyridines, on the other hand, possess myocardial suppressant effects and should be avoided in patients with heart failure. Sometimes their side effects can be disturbing, like headache, flushing, constipation, and lower limb edema. Nicorandil is not a new agent, but it stands out due to its dual mechanism of action, as both a nitric oxide donor and a potassium channel opener. The nitric oxide donation stimulates guanylate cyclase, resulting in vascular smooth muscle relaxation, vasodilating the large coronary arteries and even the arterioles. Activation of the potassium ATP channel in the smooth muscles and the myocardium causes further relaxation of the coronary arteries, can dilate the arterial vessels, reducing the afterload and sometimes the preload, ultimately improving the myocardial oxygen supply and reducing the cardiac workload. There's one landmark study on Nicorandil that demonstrated a significant reduction in the composite endpoint of mortality, MI, or unplanned admission for chest pain. Also, we have smaller studies that have suggested benefits in patients post-PCI. While Nicorandil is generally well tolerated, headache is a common side effect, and its blood pressure lowering effect requires careful monitoring. There is a unique and sometimes disturbing side effect, which is the potential for perianal and gastrointestinal ulcerations, as well as exacerbation of anal fissures and hemorrhoids, which necessitates careful patient counseling. Ivabradine is a unique medication. It selectively inhibits a specific sodium channel called the funny current, which exists only in the SA node, resulting in pure heart rate lowering without any impact on blood pressure or a negative inotropic effect. By slowing the heart rate, it increases the coronary perfusion time, reduces the cardiac workload. It often proves more tolerable than beta blockers and has shown improved outcomes in patients with heart failure and angina. That's why it was given a Class 2A recommendation in the guidelines for angina relief in patients with heart failure. However, caution is advised with concomitant use of calcium channel antagonists, and there's a slight increase in the risk of atrial fibrillation that has been observed in some studies. Trimetazidine is an example of a pure metabolic agent. It enhances the heart's efficiency in utilizing oxygen during ischemia by shifting myocardial metabolism from fatty acid oxidation to glucose oxidation. This preferential use of glucose reduces the oxygen consumption, thereby preserving energy and improving the cardiac efficiency under ischemic stress. Smaller studies have suggested potential benefits in heart failure and in diabetic patients, but a large trial in the post-PCI setting did not demonstrate a significant benefit. It's generally very well tolerated, with no direct effects on blood pressure or heart rate. The most notable side effect is a reversible worsening of Parkinsonism in susceptible individuals because of dopamine-related mechanisms. Ranolazine is the newest among the antianginal medications, and its antianginal effects are likely mediated through multiple actions on the ion channels. The primary mechanism being the selective inhibition of the inward sodium current. By reducing intracellular sodium, ranolazine indirectly reduces the calcium overload, leading to improved myocardial relaxation, reduced diastolic stiffness, and enhanced coronary blood flow. It also exhibits weak alpha-1 and beta-1 adrenergic receptor antagonism, though this is thought to play only a minor role in its antianginal efficacy. We have multiple large randomized control trials and systematic reviews that demonstrated the efficacy of ranolazine in reducing the frequency of anginal episodes and the need for sublingual nitrates. The side effects of ranolazine are usually mild, such as headache and dizziness, but there's one serious consideration, which is QT interval prolongation. Careful attention to potential drug interactions that can elevate ranolazine levels and increase the risk of QT prolongation. So, having reviewed the pharmacological landscape, how should we tailor these antianginal medications to individual patients? There are three practical strategies to guide the tailoring of antianginal medications: hemodynamic considerations, coronary pathophysiology, and comorbidities. So tailoring based on hemodynamics. If we look just at the heart rate and the blood pressure, and we take cutoffs of heart rate 60 beats per minute and blood pressure of 120 millimeters mercury systolic, then we'll have four possible situations. Let's start when the heart rate is more than 60 and the blood pressure is more than or equal 120. Here we have the luxury of using many antianginal medications: beta blockers, calcium antagonists of different kinds, Ivabradine, Nitrates, Nicorandil, Ranolazine, Trimetazidine. We can practically use anything. If the heart rate is more than 60 but the blood pressure is less than 120, then any vasodilator agent would be out of the equation. Beta blockers, calcium antagonists, nitrates, Nicorandil are out, and we're left only with metabolic agents, Trimetazidine, Ranolazine, and of course Ivabradine, because it has no effect on the blood pressure. If the heart rate is less than or equal 60 beats per minute, but we still have a good systolic blood pressure, then we can use dihydropyridine calcium antagonists because they can cause reflex tachycardia, nitrates, Nicorandil, Ranolazine, Trimetazidine. Of course, we will not use Ivabradine, we will not use beta blockers, we will not use non-dihydropyridine calcium antagonists. A heart rate that is less than 60 and a blood pressure that is less than 120, here we have serious limitation with hemodynamic agents, and we are left only with the metabolic agents, ranolazine and trimetazidine. We can also tailor the antianginal therapy based on the pathophysiology of coronary disease. Looking at patients with ANOCA, remember in the last episode we classified them into either abnormal vasoconstriction or abnormal vasodilatation. Abnormal vasodilatation, which is the microvascular disease. Here nitrates will not be very effective, but we can give beta blockers, calcium antagonists, and the metabolic agents because they will act on reducing the myocardial oxygen demands and improving the myocardial oxygen supply. When we have endothelial dysfunction and abnormal vasoconstriction, that involves the epicardial vessels, then beta blockers are out, and the best agents will be those that relax the epicardial vascular smooth muscle cells. So calcium antagonists, nitrates, and Nicorandil would be the best for epicardial vasospasm. For microvascular vasospasm, nitrates can work, calcium channel antagonists can also work. These would be the best agents for microvascular spasm. Tailoring according to comorbidities. We have the famous diamond approach, which was endorsed by the European Society of Cardiology. The diamond approach helps us to understand the indications and the contraindications of each of the common anti-anginal medications and which agents can be combined together and which agents should not be combined together. Beta blockers, useful for obstructive coronary disease, microvascular dysfunction, hypertension, atrial fibrillation, heart failure. Cautious in patients with COPD, peripheral arterial disease, type 1 diabetes, and contraindicated, of course, in patients with sick sinus syndrome. Beta blockers can be combined with nitrates, Nicorandil, hydropyridine calcium antagonists with no issues. Dihydropyridine calcium antagonists are useful in obstructive coronary disease, vasospastic angina, and patients with hypertension, but they are of no value in patients with heart failure. Non-dihydropyridine calcium antagonists should not be combined with Ivabradine. They're useful in obstructive coronary disease. In vasospastic angina, they control the rate in atrial fibrillation, should not be used in patients with heart failure and reduced ejection fraction, and in patients with sick sinus syndrome. Trimetazidine and Ranolazine, both metabolic agents, useful for both epicardial obstructive disease and microvascular disease. Ivabradine is a very good option for patients with heart failure and reduced ejection fraction, but not for patients with sick sinus syndrome because it increases the chances of atrial fibrillation. Nitrates and Nicorandil are good for obstructive coronary disease, vasospastic angina. They are not very useful in heart failure with reduced ejection fraction. They do not improve the outcome. And of course, they are contraindicated in patients with hypertrophic cardiomyopathy and concomitant use of phosphodiesterase 5 inhibitors. Then, in cases where angina persists despite optimal medical therapy and the patient is not a candidate for revascularization, several procedural options offer hope for symptom relief. Laser myocardial revascularization is a rather older technique that involves creating channels in the left ventricular myocardium using laser. The aim is to improve the blood flow to the ischemic areas, either directly through oxygen diffusion or by stimulating angiogenesis. Laser myocardial revascularization exists in open and percutaneous forms, but the evidence supporting the efficacy is stronger for the open surgical approach. It can be effective in relieving angina, but it's an invasive procedure with associated surgical risks, and there's also a possibility of a placebo effect. Coronary sinus reducer is a percutaneously implanted hourglass-shaped stainless steel mesh that creates a controlled narrowing in the coronary sinus, which is the primary venous drainage of the heart. This intentional stenosis increases pressure in the coronary venous system, which is believed to redistribute the blood flow from the well-perfused subepicardium to the more ischemic subendocardium. It may also enhance subendocardial perfusion by dilating arterial capillaries and reducing microvascular resistance. The benefit develops gradually over 1 to 3 months after the procedure as the device starts to endothelialize. We have multiple randomized placebo-controlled trials that have demonstrated that coronary sinus reducer leads to a significant reduction in angina frequency and improved quality of life in patients with refractory angina. The procedure is considered safe with a very low complication rate. Stem cell therapy has a promising future. CD34 stem cell therapy shows promise in alleviating angina, particularly in refractory cases. The proposed mechanism involves promoting new blood vessel formation in the ischemic areas and releasing growth factors that reduce inflammation and enhance tissue repair. We have a meta-analysis of more than 600 patients that demonstrated improvement in the angina class and also improvement in myocardial perfusion effects without major safety issues. However, the benefits like exercise tolerance may wane after 12 months, so it needs repeated administrations. While the field is evolving and promising, stem cell therapy holds significant potential for the future of angina once the optimal cell types, the dosing regimens, and the regulatory frameworks are established and integrated into the clinical guidelines. We had an interview in our channel with one of the international experts on stem cells, Dr. Yahya Kiwan. You will find the episode in the channel, and I will add a link to that episode in the description. Spinal cord stimulation is another promising technique for relief of angina. It involves the activation of the large diameter sensory fibers in the dorsal columns of the spinal cord, inhibiting the transmission of pain signals. These pain signals are carried by the small C fibers. This is called the gate control theory. Beyond pain modulation, spinal cord stimulation may also decrease the sympathetic tone, so it can redistribute blood flow to the ischemic areas and improve microcirculatory perfusion. The spinal cord stimulation system comprises electrodes that are placed epidural near the spinal cord and leads connecting the electrodes to an implanted pulse generator. The electrodes are typically placed at T4 to T6 level and can be advanced to the cervicothoracic junction C5-C6 to overlap the anginal pain area with the stimulation-induced paresthesia. Spinal cord stimulation is safe and an effective palliative therapy for refractory angina. Interestingly, spinal cord stimulation does not mask the pain of acute myocardial infarction, allowing patients to recognize new or worsening cardiac events. Complications are primarily related to the implantable device, such as lead migration and infection. Enhanced external counter pulsations is a non-invasive, FDA-approved outpatient therapy for angina relief. Again, it's indicated for patients with refractory angina where medical treatment fails and who are not candidates for further revascularization. The therapy involves the sequential inflation and deflation of pneumatic cuffs that are wrapped around the calves, the thighs, and the buttocks, synchronized with the patient's heartbeat. Inflation during diastole increases the venous return and the aortic diastolic pressure, augmenting coronary flow and oxygen delivery. Rapid deflation just before systole reduces the afterload and decreases the cardiac workload. EECP may also stimulate collateral vessel formation and improve peripheral arterial function and general endothelial health. Enhanced external counterpulsation has been shown to significantly reduce anginal frequency and severity. It also improves the exercise capacity and quality of life. The benefits are typically maintained for 6 to 12 months after the 7-week course of daily 1-hour session. It's generally safe and well tolerated with minimal side effects, offering a valuable non-surgical option for patients with refractory angina. And now let's open the discussion. Please mention in the comments what are your favorite anti-anginal medications in challenging cases. What practical strategies do you employ to tailor these medications to your individual patients? And what are your thoughts and experiences with these procedural options for refractory angina? Your thoughts provide valuable lessons for all of us.
Thanks so much for tuning in to Cardio Buzz today. We really hope you found our chat about tackling angina helpful and insightful. We'd absolutely love to hear your thoughts and experiences in the comments below. If you enjoyed this episode, please give it a thumbs up and share it with your fellow healthcare heroes. And if you're not already part of the Cardio Buzz family, hit that subscribe button and ring the notification bell so you don't miss out on future deep dives into the fascinating world of cardiology. Catch you next time on Cardio Buzz. Stay heart smart.